Thanks, and welcome to our panel discussion on hot topics in GI malignancies. We have an esteemed panel here. We actually have 3 surgeons, 1 radiation oncologist, and 2 medical oncologists, really appropriately balanced according to the importance of the different disciplines. And I would like our panel to, Noam, we'll talk about that, the importance of radiation therapy. I know you're hurt right now. I would like to go around the room more or less and have people introduce themselves. Dr. Dickson, Paxton?
Paxton Dickson, surgical oncologist focused in upper gastrointestinal malignancies at the University of Tennessee Health Science Center.
Okay, Dr. Glazer, Evan Glazer.
Good morning. My name is Evan Glazer. I'm a surgical oncologist at the University of Tennessee, and I focus on hepatobiliary and pancreatic malignancies, and including metastasis.
Okay. Dr. Shibata, Dave Shibata.
Hey, good morning, everyone. Thanks for having me, Axel. My name is David Shibata. I'm a surgical oncologist, and I focus on colorectal cancer. I'm also at the University of Tennessee. Thank you.
Dr. Vanderwalde, Noam.
Good morning, everybody, and happy Purim for those who are celebrating. Noam Vanderwalde. I'm a radiation oncologist, and I focus on GI cancers and also in geriatrics at the West Cancer Center.
And all of us are based in rainy Tennessee right now. We have Dr. Botta from UCSD, as joining us. Greg, you're in sunny San Diego.
Yes, Axel, thanks so much. Yeah, sun's just coming up now. We are at UC San Diego. I'm a gastrointestinal medical oncologist, specializing in GI, rectal, pancreatic cancer, and we have a translational lab as well here. So really happy to join. Thanks, everyone.
Perfect. Okay, so let's dive in, and I have prepared 2 cases which I'd like us to discuss, kind of like an interdisciplinary tumor board. One is rectal cancer, one is pancreas cancer. I think these are the areas where the interdisciplinary team approach is critical and more critical, actually. So first patient is a 67-year-old male patient, has a history of 2 months of blood and bowel movements, pain in the rectal area. Colonoscopy identifies a semicircumferential mass measuring about 2 centimeters at 4 centimeters from the anal verge. Circumferential margin per MRI criteria is not threatened, and biopsies confirm a moderately differentiated adenocarcinoma. MMRP, CAA is 4.5, so kind of borderline. So David, what information do you need in order to really assess, what's the strategies? Because I do believe that the surgeon leads the way here in terms of surgical planning, etc. And I would like to also to address who determines the location of the tumor from the anal verge or from the anal sphincters. What is important here?
Well, lots of questions there, a couple of loaded questions, but certainly happy to answer some of those. So I think really critically, obviously, as per any type of cancer workup, I think the staging is critical. I think for rectal cancer in particular, local staging is very important, as well as the distant staging. The distant staging, I think, is very straightforward, looking for systemic metastasis. CT scan, chest, abdomen, pelvis is usually would be the standard. Certainly, though, for local staging, the trend and the preferred approach has gone to a rectal protocol MRI at this point, so that's key. For the chest of the CT of the chest and abdomen is probably adequate if you're doing an MRI of the pelvis anyways. That's just kind of a little nuance there, but certainly the initial staging is really critical, both local and distant. Secondly, I guess, and you may be getting to that, but the physical exam obviously is very critical for rectal cancer. We often talk about the rectal cancers being from the anal verge, but truly the most important distance metric is that from the top of the anal rectal ring. So really to understand where a cancer lies with respect to the sphincter is very important for many reasons, including sphincter preservation, and certainly around that, the issue of treatment planning, particularly in this era.
Very good. So who determines the location? Is it the surgeon using a rigid proctoscopy, which I sometimes see in guidelines, or is it based on MRI criteria? Is it just based on the physical exam? So what defines the location of the cancer really?
In terms of pure distance, one would say that the most accurate is using a rigid proctoscopy, particularly with respect to lesions that are beyond feel of a digital rectal examination. So you're kind of really getting a very accurate distance with a rigid proctoscope. Some would argue that you could do it with a flexible, but for the most part, surgeons would agree that you could actually get a better distance measurement using the rigid proctoscope. Now, that being said, probably once again, the most important measurement is that of the distance from the anal sphincters, and that is by far for the distal rectal cancers a digital rectal exam would even be much more accurate than any other modality in terms of judging what involvement there is of the sphincter. So the surgeon's involvement is very critical for this, I would say. That being said, also this day and age, the MRIs have gotten much better, and you can certainly get some gauge of radiologic involvement of the sphincter, distance from the sphincter complex and the anal verge. So this day and age, we have many modalities that provide us a distance, and with all those together, it's very helpful to make decision making. So one can draw information from each of those modalities.
Okay, so this patient underwent a CT, chest, abdomen, no evidence of distal metastasis, MRI pelvis. Already mentioned kind of when you had no circumferential margin not threatened. It's a T3 lesion, but there's one suspicious 7mm perirectal lymph node that is called out. And Greg, I know what we're doing in Tennessee, as we discuss our patients in our interdisciplinary tumor board. Almost every rectal cancer patient, actually, I believe. So how do you handle this in San Diego? And you're muted right now, okay.
Very similarly, we have a multidisciplinary rectal tumor board, part of the NAPRC, in which we have both the radiologist, radiation oncologist, medical oncologist, and surgical oncologist on board. Usually for these patients, anyone who is at high risk of a margin positive resection or frankly lymph node positive, we are initiating a total neoadjuvant therapy approach and moving forward with chemotherapy followed by radiation. Long course and short course is always discussed, and then moving towards either resection with adjuvant therapy or resection alone.
Yeah. So in your presentation, which I actually listened to, you've highlighted all the different approaches that came out at ASCO last year. We have short course, long course, sequencing, non-optive management. There's so many different dials we're turning in right now. So let me ask you, what is a patient that from your end would not be a candidate for total neoadjuvant therapy? Is it stage-based, age-based? What are you looking at?
That's a great question. So there is some patients it's a functional status. We definitely are seeing more younger patients, I would say, nowadays with rectal cancer than we were used to seeing, but there are still the occasional 80-year-old patients who have a poor functional status. And what we do, at least at West, is we do a geriatric assessment on them. And if they're really frail and we do not think we're going to be able to do a curative trimodality approach on them, then I do not think that we should be leaning towards a TNT approach in those patients. And sometimes we've just gone with a palliative approach to help their symptoms and make sure that they continue to have a good function, as they may have other diseases, other comorbidities that may affect them more than their cancer. But for the most part, in patients that are either pre-frail or robust, if they have node positive disease or locally advanced disease, FOLFOX is pretty tolerable in a lot of patients. And so we do try to use that TNT approach in most patients.
Okay, so COVID has brought us a lot of made us think. And one of the points of COVID that came about in a positive way is looking at short course versus long course radiation therapy, just less exposure of patients to healthcare facilities. And this is interesting because short course radiation therapy has been around for a long time, but we tend to not really, I wouldn't say we tended to ignore it, but really didn't adopt it as readily. So has this changed now? Is Rapido the new standard of care? Or now, from your perspective, where do you see the role of radiochemotherapy now? Do you have to make a case for long course radiation therapy now?
I'm assuming that question is to me.
Yes,
but I would say yes. to both of those questions, I think with COVID around at least the US, short course has become a lot more common than it was probably before COVID and also probably before ASCO. That being said, I do not think that short course is appropriate for everybody. And probably the most common thing that we find in our patients who have very low-lying rectal cancers that would require APRs and, you know, or patients that are really interested in non-operative management. And I think that right now, there is not very good data on the use of short course radiation therapy in non-operative management. And we do see a lot of patients who are interested in non-operative management. And so for those patients, I tend to lean more towards a chemoradiation therapy approach and, you know, a TNT approach in those patients. But in other patients, if their tumors are high enough above the internal sphincter, yeah, we are trying to use more short course in those patients as the data is pretty good. Yeah.
David, you know, to you again, you know, non-operative management. I mean, is this really, I mean, can we plan upfront for non-operative management, or is this something that evolves over time, like you know that you're getting there when you see it over time when you embrace a TNT approach?
I would say our approach, and particularly how we talk to patients about this, has changed with the emerging data. I would say maybe several years ago, where this was starting to gain traction, we had some data from Brazil, from Dr. Habergama's group, that this could be possible. Never got a lot of traction or reproducibility in various different other countries, including our own. But that being said, it became more and more apparent that there's definitely a subset of patients that would have a complete response and that never needed surgery. It's that selection was still it was difficult then, and still a little bit difficult now. However, we know that it's possible now. So back in the day, we used to we wouldn't tell patients about this until we've discovered at the very end that, you know what, your cancer's gone, maybe we can do this. At this point now, though, we are in a situation, because it's really out there, it's on Dr. Google now. And so I think that we have to talk to patients about this beforehand and give them the data that we know. There's a certain number of patients that will respond. You may or may not respond in this fashion. And if you do, you may or may not respond in the long term. So you really lay it out for them. And in particular, patients who are faced with very low-lying cancers, risk of kind of losing their sphincters, those patients do like to hear about this, and being upfront with them about this, I think, is very helpful. So it's very much a changing landscape now, and hopefully we'll continue to get kind of more level 1 evidence to help us with this decision making.
Yeah, and it's actually something which I am very interested in because it's driven by surgeons. You know, when you look at the Memorial Group, it's the surgeons who actually really lead the way in terms of non-operative management. Greg, you know, one of the issues that we have when we talk about, you know, the completeness of response, we look at imaging characteristics, you know, clinical, so DRE, etc. Can ctDNA help us here in this setting? How much data do we have for ctDNA in rectal cancer? Because you looked at minimal residual disease. Is this something that can help us refine the patient population?
No, you're absolutely correct. So we've implemented this for a number of patients, especially during COVID, with operating rooms shutting down, using more of a watch and wait approach with ctDNA. We have to remember that ctDNA is going to be positive in patients who have either threatened fascia or the possibility of lymph node positive disease. Whereas local disease, they may not shed ctDNA into the circulation, and they may still have disease present. And we make them aware of that during their watch and wait and evaluation, following with both MRIs and exams. If you look at most of the data, the watch and wait approach, the patients have similar outcomes, but most patients who have regrowth and salvage surgeries are due to the fact that there's local regrowth, and the ctDNA may not actually pick that up. So I think that we always talk about that with our patients ahead of time. That being said, we do implement ctDNA as a watch and wait approach and follow patients with standard of care imaging and exams along with it.
Mm-hmm. So Evan brought up a point which I like to pick up on: oligometastatic disease and rectal cancer. And that is something which we see. Actually, we have patients, you know, in treatment right now where we think, you know, these patients have a curative intent, you know, with liver resection, for instance, or even lung resection. And what do we need to do locally in order to make sure that the patient has a high local curative chance? Do we still radiate those patients? Evan, did I kind of paraphrase your question right?
Yeah, absolutely. I think it's a very interesting question. Historically, which is only a few years now, I've always favored a synchronous resection. The risk benefit generally favors either approach, any of the three approaches: metastatic disease first, local regional first, or combined. And I've favored one operation logistically easier, and the risks aren't higher in the properly selected patient. But at the same time, as we now have a patient that we all share currently, literally rectal cancer, threatened margins on the rectum, and not inconsequential liver disease burden. And so strategically, how do we go for curative intent in this patient really is a tough question, certainly multidisciplinary in nature. And to speed things along just a little bit, on one hand, how do we ensure that we can address the threatened margins? And is that chemotherapy? Is that radiation? Is that a lot of radiation? Is that little radiation? And then the second question is, how do we handle this treatment-free interval on the liver, whether it's through liver-directed therapy or through just watching very closely? I think it's an interesting question, but more importantly, a really clinically relevant question.
Yeah, I think that's really where the multidisciplinary approach, really talking about this patient, not just once, but repeatedly along the course is critical, because we don't want to lose these patients. There are a couple of questions which beyond, the outline that I provided is kind of for a bulky tumor prior to surgery, is radiation plus capecitabine standard for stage 2 rectal cancer. I would say yes, that's one. But we have really stage 2. We have, if you have a bulky tumor, we've also used chemotherapy, and I do believe that chemotherapy brings a faster relief, from local symptoms than radiation therapy, and even Noam has to agree to that, I guess. We talked about this, which works faster, chemo or radiation. Fastest, of course, is surgery because we take it out, but in terms of chemo or radiation, I think it's chemotherapy beats radiation therapy here.
Yeah, that's definitely been my experience as well.
Okay, so we are halfway through our discussion. I'd like to focus on pancreas cancer now, and really get a vignette here. 63-year-old female patient, great performance status, has obstructive jaundice from a 2-centimeter mass in the head of the pancreas, no real vessel involvement. US biopsy confirms adenocarcinoma, biliary stent is placed, jaundice resolved, CA19-9 is 35, so pretty low. CT scans, chest, abdomen, pelvis, no evidence of distant metastatic disease. So this is from what I wanted to see. And I know, Paxton, I want to get you involved because you are kind of driving right now, and you're probably looking at a much more beautiful landscape than we are looking here, because I don't want to say where you are. This is a clearly resectable pancreas cancer, upfront resectable, no question about that. Do you need neoadjuvant treatment? What do you think?
I would answer that as that we need chemotherapy. We know that. We know that the best outcomes for patients, regardless of stage or resection and chemotherapy. And so we prefer, as was outlined in the talk.
Yeah, you're breaking up a little bit.
These patients.
Yeah. Let me pick up on that. The idea is we need chemotherapy in this context because adjuvant therapy works to prove. Yeah.
Yeah, there's.
I think that's.
There's very good data that adjuvant therapy is very helpful and very good. There's also pretty good data that lots of patients won't receive adjuvant therapy, upwards of 60%. And so from purely a statistical perspective, there's a compelling argument that more patients will get more benefit from more chemotherapy up front in this patient population, given the overall comorbidity and 40 to 50% complication rate, even in the very best hands.
Yeah, so I mean, that's actually something which we decided on as a team here, to really recommend neoadjuvant treatment for virtually all patients. I mean, and Greg, I would like to see, is this something you have embraced too? I mean, the the real strategy all across, not just GI, but all across oncology, is really neoadjuvant systemic therapy. And I think with the more targeted approaches, immune therapy approaches, once we have the data, we'll see even more of this come up. So what are you doing in UCSD?
I would agree fully with you. We've discussed this as well with Andy Lowy, Rebecca White here. And the idea is that this is a micrometastatic disease at inset. And these patients, even with early disease and looks like resectability with low CA19-9, likely based on preclinical models, already have circulating tumor cells. And we're doing a neoadjuvant approach. I agree fully with the idea that this is the time that the patients can handle a regimen such as FOLFIRINOX, their healthiest state, and helping to proceed to a surgery. We also know that patients who have adequate CA19-9 and no evidence of disease who go to surgery sometimes find micrometastatic disease on the liver. And I think that we need to avoid those situations going to surgery and closing.
Yeah, it's interesting that you say that. I mean, Paxton, we've discussed, and Paxton is offline, I know that. We have discussed, and I think Evan is on board on that too, diagnostic laparoscopies in these patients. Really at the same time when you put a port in, from a surgical perspective. So it's one-stop shop. And I had 2 patients actually last month where a laparoscopy identified actually liver metastases, which were not seen on scan, small little things. And this changed our approach, of course, completely. I mean, the intent, not the chemotherapy necessarily up front, but the intent of the cancer. So intent of the treatment. So Greg, were you surprised by the SWOG study that showed that FOLFIRINOX and gem-nab-paclitaxel had similar performance in this? I mean, it was kind of 2 arms conducted separately, not really, there was not a formal comparison, but we all compare, of course. And there was kind of, when you benchmark it and eyeball it here, there was no difference in outcome for patients with the resectable cancers, FOLFIRINOX versus gem-nab-paclitaxel.
No, I would agree with you. When you look at the more contemporary gem-nab-paclitaxel studies, their overall survival rates are actually very similar to the FOLFIRINOX data that came out originally. We're looking at 11-month overall survival now, greater than the original 8.5-month survival. So I don't think it was too surprising to see that they were equally efficacious. Knowing that the adjuvant data for gem-Abraxane is up in the air, I think the perioperative data further solidified that gem-Abraxane can be a regimen that is used in this setting. What was interesting to me more than anything was the side effect profile for gem-Abraxane compared to FOLFIRINOX. It seemed like some patients actually had a little more difficult time with gem-Abraxane over it. So, I think some of these mindsets that we have that gem-Abraxane is easier or it's less ineffective than FOLFIRINOX, I think are being challenged right now.
Yeah. So, Evan,
I think your point on the receiving end of those patients after they go through this is really critical. That it goes both ways. That there's both patients who respond very well and then end up their performance status improves and they do great. And with gem-Abraxane, FOLFIRINOX, and vice versa. Certainly, in the lab, both of us with translational labs, there's a lot of data that tumor response is the kicker. And a lot of the tumor patient interactions and why some tumors respond so well to gem-Abraxane but not FOLFIRINOX and vice versa. There's some molecular signaling issues with GATA6 and things like that, but I really think there's a Nobel Prize in there to figure out just how that response manifests, and it's certainly relevant to pancreas.
I would agree with you, and I think that there are some patients that we switch therapy on from FOLFIRINOX to gem-Abraxane and vice versa, and get an amazing response that we didn't normally see. And I believe that this needs to be evaluated further as well.
Now that's a great point, because I've noticed that too. If some patients respond to FOLFIRINOX, some patients respond to gem-nab-paclitaxel, and we have actually also switched, treatment. I normally start with FOLFIRINOX, get 4 rounds of treatment, get a scan, see what happened. You have CA19-9 course, and then really discuss. Because if patients show, let's say, some form of progression, including CA19-9. I think it would be wrong to move them to surgery because, that is exactly, you don't want to do surgery in a growing dynamic malignancy. And so then we normally switch treatment and then try to see what happens. Yeah. So Noam, we need to talk about the topic of radiation therapy in pancreas cancer. And I can tell you when I came to America, 2003, Mayo Clinic at that time was following the Gitzik protocol, looking at, radiation therapy with bolus 5-FU after, and then they ignored the study data, actually, that 5-FU was continued for 2 years in the initial study. And it took so long to, really find the place or no place for radiation therapy in the management of pancreas cancer. So what do you think? Who is there a patient in the neoadjuvant setting that should get radiation therapy? And I don't want to put you on the spot to try to explain the Alliance trial that really threw us into a loop here. And if you do radiation therapy, what kind of radiation are you using?
Yeah, all great questions. My personal belief is there is not a role for radiation in resectable or resected with negative margin patients, but in the borderline resectable, I think the question is still out there. And I know Paxton showed the pre-OPANC data, and that data with a planned analysis in the borderline patients actually showed survival improvement in the patients who got chemoradiation. Now that study obviously was not a FOLFIRINOX plus or minus radiation study. It was chemoradiation in the neoadjuvant setting versus nothing in the neoadjuvant setting. So there's definitely, we need studies to look at FOLFIRINOX plus or minus radiation in this setting. And I know the Alliance trial did that, but the Alliance trial definitely has some issues, including the type of radiation that was used. I think SBRT probably not, at least the way the SBRT was given on the Alliance trial, probably not the right way to be treating these patients, at least according to the data we have now. Should we be using more like long course chemoradiation as did the original Alliance trial and other single institutional trials? Maybe. Should we be using pre-OPANC, meaning just 36 gray and 15 fractions? Maybe. Should we be using kind of dose escalated SBRT where we can give higher doses of radiation and also give kind of lower doses to surrounding nodal tissue? Maybe. All of those trials are being performed and looked at. Honestly, I don't know the answer right now. Our clinical, what we do clinically right now is it's a very multidisciplinary decision. We look at the imaging, we talk with the surgeons, we decide, do we think we're going to be able to take this out or not? Do we need more of a response? Where do we need the response? I know Paxton and Evan and I have actually sat down and contoured out some of these patients together in terms of the radiation planning. So what I would suggest now to folks is just do this in a multidisciplinary fashion. There are some patients who are, we call borderline, but probably are really resectable. Maybe those patients don't need radiation. And we have some patients that are borderline that are kind of more like a locally advanced patient. And maybe those patients do benefit from radiation. I think time will tell.
So I like to end up on, just what you said, multidisciplinary approaches, talking about patients, really getting the team built around the patient, is critical. And I think we need to wrap up the panel because, the conference is moving along. Thank you for everyone here to participate early morning in California. I know and Paxton is close to you, actually, where he is right now. I also want to take a moment to thank all of the exhibitors for the support of the meeting. We're heading into a break, and it's a perfect time to earn points. You can earn points by visiting the exhibits, engaging with industry representatives. Without them, the meeting could not happen. That's important. And we'll meet back in the general session for updates on genitourinary cancer. And yes, Evan reminded me, I need to make a comment on the manel that we have here. This is not intentional. I mean, we do need, and there's something we need to keep in mind, have more diversity in our group of physicians and that discuss cases. So yes, it's a manel and it should be a panel, and we'll take this to heart for next year. Okay, thank you everyone. Thank you. Bye-bye.